Hi, my name is Osama. Naga will discuss in this video Pediatric Neurology Board Review.
Check all the updated information in the third edition 2024-2025.
Neurological examination. It is very important to know the difference between upper motor neuron lesions and lower motor neuron lesions. Upper motor neuron lesions is interruption of neuronal pathway in the brain and the spinal cord before the anterior horn cells. Damage from the anterior horn cells outside the brain and the spinal cord is considered lower motor neuron lesions. Patients with upper motor neuron lesions, they present with weakness in all muscle group. They have less muscle wasting. In the other side, lower motor neuron lesion, they have weakness which is more distal, and they have more muscle wasting. Patient with upper motor, they have spasticity and rigidity. Lower motor, they present with hypotonia or flaccid paralysis. For upper motor neuron lesions, their reflexes are exaggerated and increased. Cases of lower motor neuron lesions, the reflexes are reduced. Babinski is positive, or Babinski reflex is positive in upper motor neuron lesions, which is upgoing 2. This is normal in newborn infants and younger children less than 2 to 3 years of age. Persistence beyond 2 to 3 years of age of Babinski reflex is abnormal. Fasciculations is a significant sign of lower motor neuron lesions, which is repetitive movement of the muscle. A study of a choice for upper motor neuron lesion, CT scan for the brain, MRI can be used for the brain and the spine. Study of a choice for lower motor neuron lesions is nerve conduction studies, electromyogram, and creatine kinase. Neurological imaging, acute events with suspected intracranial bleeding or hemorrhage. The best study is CT scan without contrast. CT scan without contrast for any acute event, like for example trauma with suspected intracranial bleeding. The best study is CT scan without contrast. Head ultrasound is an excellent choice in neonates with suspected intraventricular hemorrhage. Actually, it is used and a very useful tool for screening preterm infants for intraventricular hemorrhage. Intracranial structure abnormalities, for example tumor or any abnormal anatomy, the best study is brain MRI. This will show a lot of details without the amount of radiation you will obtain from the CT scan. Spinal cord, even in the acute event, MRI is the best study. We'll start with seizures. Classifications of seizures can be simple partial seizures, which is no impairment of consciousness and also no loss of consciousness. Can have motor, sensory, or autonomic features. Can complicate to become a complex partial seizure. What is complex partial seizure? Is simple partial seizure with impairment of consciousness. Not necessary to be loss of consciousness, just impairment of consciousness can make it complex partial seizure. Both simple and complex seizure, they can generalize. Generalized seizures, for example, absence seizure or petit mal epilepsy, myoclonic, clonic, tonic, or tonic-clonic, which is grand mal epilepsy, or atonic with sudden collapse. First type of seizure, we'll discuss febrile seizure. Febrile seizure affects 2 to 5% of children. It is very common. This is the most common childhood seizure type in general. The most common type of seizure is febrile seizure. Affects children between 6 months and 5 years of age. Risk factors: the peak temperature during the illness or the highest point of temperature during the illness. History of febrile seizure in first degree relative, neurodevelopmental delays, increased exposure to human herpes virus type 6, which is a common cause of rosula infantum, vaccination with measles, mumps, rubella, diphtheria, tetanus, pertussis, and influenza vaccine. Know that 50% of cases or 50% of the cases, they do not have identified risk factor. The difference between simple febrile seizures and complex febrile seizure. Simple febrile seizures, a brief generalized seizure. The complex can be focal. A simple one is less than 15 minutes. The complex one is more than 15 minutes. The simple febrile seizure does not recur within 24 hours. If it does recur more than once within 24 hours, is considered complex febrile seizure. Also, the febrile illness does not involve the CNS. For example, a febrile seizure is not because of meningitis. If it's because of meningitis, you cannot call it simple febrile seizure. It is critical to make sure that children with febrile seizure do not have CNS infection. So you need to know the indications for lumbar puncture. Any infant less than 12 months present with a febrile seizure must have lumbar puncture to make sure it's not because of meningitis. Prolonged complex febrile seizures, febrile status epilepticus, children who are partially treated with antibiotics. Other than that, generally you do not need to do lumbar puncture, or anytime you suspect meningitis or CNS infection you must perform lumbar puncture. Classic presentation of febrile seizure usually do not require any blood work. If you will do blood work, will be for the febrile illness if you want to know the cause of the fever, but not for the seizure. EEG is not necessary for simple febrile seizure. Neuroimaging also is not routinely needed for simple febrile seizure. Management of febrile seizure is supportive. Educating the parents about the course of the disease is very important. Treatment of the underlying febrile illness. If it's acute otitis media, you need to treat. If it's because of rosula infantum, for example, you have to reassure the parents about the course of the disease. Rectal diazepam may be helpful in some cases if there is a risk factor for recurrent febrile seizure, prolonged febrile seizures, and very low threshold for febrile seizures. It is not routinely recommended to give a daily prophylactic medicine to prevent febrile seizure. Risk of recurrence of febrile seizure is very important for teaching the parents. This will decrease the anxiety, especially when the infant or the child is having the second attack of febrile seizure. Younger age of onset, the younger the child or the infant, the higher the risk of recurrence. Having an initial febrile seizure with a relatively low temperature. For example, if you have an infant having febrile seizure with fever 100.4 Fahrenheit, the risk of recurrence is higher than an infant having a febrile seizure with 105 Fahrenheit. Family history of febrile seizure in a first degree relative, risk of recurrence is high, is about 60% after the initial febrile seizure. So for the parents, knowing that there is a likelihood for the seizure to come back, this will decrease their anxiety when the child is having the second attack. Approximately 2 to 10% of the infant with febrile seizure, they may develop epilepsy or they experience epilepsy. So this is a question the parents always ask and is common in the board. Neonatal seizures. Causes of neonatal seizures: hypoxic ischemic encephalopathy is the most common cause. Intracranial hemorrhage, ischemic strokes, infections, and which is very important, critical, that's why I put it in red, to rule out infection in any neonate presents with seizures. Bacterial and viral also can cause that, especially herpes simplex virus. Hypoglycemia can cause neonatal seizures, hypo or hypernatremia. Hypocalcemia, hypomagnesemia, inborn error of metabolism, certain genetic disorders can cause neonatal seizures. The clinical presentation is not simple to recognize or to see seizures in neonates. It can be subtle tonic or clonic movements of one limb or automatism, like for example lip smacking or thrusting of the tongue. Laboratory evaluation for neonatal seizure is very important to rule out sepsis, metabolic abnormalities, and hypoglycemia. EEG, neuroimaging study to look for underlying structural abnormalities. Know that jitteriness can be associated with hypoglycemia or even hypocalcemia. Treatment of neonatal seizure should be treated aggressively. The treatment of the suspected sepsis, either bacterial or herpes simplex virus, should be initiated quickly. Treatment of the underlying etiology such as electrolytes, abnormalities, for example hypocalcemia, also hypoglycemia, should be treated quickly. Phenobarbital is the treatment of a choice. Prognosis of neonatal seizure depending on the underlying etiology and response to treatment and gestational age. Most resolve within 1 month. Increased risk of developing motor and cognitive delays associated with neonatal seizures. Know that the 50-day fits is benign, which is well known as benign familial neonatal convulsions, with seizures occurring in the 5th day or 6th day of life. It is self-limited. Infantile spasm, from the name, presents during infancy between 4 and 7 months. The spasm or the contraction is a rapid flexion of the trunk, neck, and extremities. The infant will look like self-hugging. Contraction can last for 5 to 10 seconds, followed by brief relaxation, 0.2 to 2 seconds. Occurs in clusters, in group, dozens of clusters. The clusters can last less than a minute to 10 to 15 minutes. The infant often cry because the spasm is painful. more common before sleep and upon awakening, and can also occur throughout the day. Common associations, very important to know. Tuberous sclerosis commonly associated with infantile spasm and hypoxic ischemic encephalopathy. West syndrome is very important to remember because of the association with infantile spasm. So West syndrome is 3 criteria: infantile spasm, hips arrhythmia on EEG, which is high amplitude spike and waves on irregular and chaotic background. And the third component of West syndrome, developmental regression. So West syndrome is infantile spasm, hips arrhythmia on EEG, which is high amplitude and spike waves on irregular background and or disorganized background, and developmental regression. The diagnosis of infantile spasm clinically and on the EEG is unique about infantile spasm, hips arrhythmia, which is triad of high amplitude, disorganized background, multifocal discharges. The treatment is different than other types of seizures. This one will be treated with ACTH. ACTH is, you have to know that, extremely expensive. Vigabatrin if the spasms are symptomatic in a patient with tuberous sclerosis. So the drug of choice for a patient with tuberous sclerosis is vigabatrin. Prognosis, if not treated early or effectively, this increased risk of developmental delay and intellectual disability. That's why in the board and the clinical is very important, because you have to diagnose it and you have to treat it early to prevent this complication, developmental delay and intellectual disability. Childhood absence epilepsy, the typical age 4 to 8 years of age. It is not classic presentation to have 15 years old with new onset of absence epilepsy. You should look for something else. Absence seizure is common and characterized by stirring and behavioral arrest from the name absence. Can be associated with eye blinking or eye flutters. The episode will last for few seconds and the child will rapidly return to the baseline with no post-ictal sleep or fatigue. Typically occurs daily and multiple times per day. During the brief episode, the child will have memory loss during this specific time, and this can be associated with academic decline because, for example, loss of instruction from the teacher. This often can be provoked, or the seizure can be provoked with 2 to 3 minutes of hyperventilation. Diagnosis of absence seizure or petit mal epilepsy from the clinical presentation and the characteristics of the EEG. You need to remember this number: 3 Hz generalized spike wave discharge. This is and this can be provoked with hyperventilation. 3 Hz generalized spike wave discharge. This is characteristics of the EEG finding in cases of absence seizure. Treatment: the treatment of choice is ethosuxamide. The prognosis: most of the kids or the majority will be seizure free during adolescence. Benign epilepsy with centrotemporal spikes. The other name is benign Rolandic epilepsy. Benign Rolandic epilepsy. The typical onset is between 3 to 10 years of age. The key word: seizure during sleep. So seizure during sleep is benign Rolandic epilepsy, or at night, is nocturnal most of the cases, associated with facial twitching, salivation and speech arrest. This is considered focal seizure. Normal neurocognitive development, so the child is completely normal with seizures at night. The EEG will show focal discharge in the centrotemporal region, which is Rolandic region, with activation during sleep over a normal background. Treatment of Rolandic epilepsy is 1/4 of the patients will have only one seizure. Low seizure frequency, because seizures are typically nocturnal and infrequent. There is no absolute indication to treat, so reassurance is the what is required. If the treatment is considered, first line is carbamazepine because it's partial seizure or focal seizure. Prognosis spontaneously remits in a few years. Juvenile myoclonic epilepsy, the key word here, that new onset seizure during adolescence. This is the key word. So the onset of the seizure during adolescence and is between 12 to 18 years of age. Clinical presentation: generalized tonic-clonic seizure, jerking movements of the upper extremities in the morning. This is the key word for juvenile myoclonic epilepsy, and you memorize it by juvenile. So occurs in adolescence for first time. Risk factors: sleep deprivation, sleep over stress, alcohol use. Diagnosis of juvenile myoclonic epilepsy, generalized polyspike and wave discharge at 4 to 6 hertz. So remember, 4 to 6, this is a high number. The hint to remember is juvenile, occurs in adolescence, in older children, and the hertz is 4 to 6. If you compare it to the absence seizure is 3. Treatment of choice, valproic acid, and for life. The prognosis is lifelong risk of seizures. So the treatment is for life. It's not 2 or 3 years, or it is for life. Lennox-Gastaut syndrome. This is a multiple seizure type, tonic-clonic, myoclonic, atypical absence, which is maybe associated with post-ictal atonic drop seizure, like a collapse. Seizures are often frequent and very difficult to treat, and usually begin in the childhood. The EEG characteristics is diffuse, slow spike, and wave discharge at 1.5 to 2.5 hertz. So the 2 hertz is the EEG finding in the Lennox-Gastaut syndrome. And these children usually they have intellectual disability, so they are slow. So the EEG is slow, and also they have intellectual disability. It's just a hint to remember. Treatment of Lennox-Gastaut syndrome usually requires multiple medication. It is really difficult to treat. Consider ketogenic diet, which is a high fat diet, adequate protein and low carbohydrate. This will force the body to use the fat as a source of energy, and the ketone bodies will cross the blood-brain barrier, and the brain will use as a source of energy instead of the glucose. And in this case, this will reduce the seizure. Surgical options consider corpus callostomy in the patients with refractory drop seizure. Vagal nerve stimulation is another option. Prognosis, refractory epilepsy, intellectual disability. Landau-Kleffner syndrome is well known as acquired epileptic aphasia. This is a great term to describe exactly the disease. It is acquired epileptic aphasia. The onset is between 3 and 7 years of age. The key word for this disease, aphasia, and the EEG changes. It is acquired aphasia after development of normal language skills. The diagnosis, EEG changes, and the clinical presentation of language regression. So EEG changes and the language regression after normal development. The MRI is to rule out brain tumor is important. Treatment is anticonvulsants, corticosteroids, or benzodiazepines. Rasmussen's encephalitis, it is progressive encephalopathy and actually also progressive seizures. So the key word here, if you have a presentation with progressive seizure, you should think about Rasmussen's encephalitis. And it is refractory partial seizures. It is difficult to treat with cognitive decline, hemiparesis, and the imaging study will help with the diagnosis, will show atrophy in the affected cerebral hemisphere. Positive antibodies, anti-glutamate receptor antibodies, can be present in cases of Rasmussen encephalitis, and this suggests autoimmune process. Treatment is high dose of steroids, so the exact diagnosis is very important because the treatment is different than other seizures, is steroids. IVIG is another option, hemispherectomy disconnecting the affected cerebral hemisphere. This is a summary for different types of seizure with the key word of each one. The first one, infant with rapid, repetitive clusters of seizure. And this seizure can be painful and the infant may cry, is infantile spasm, and the treatment of choice is ACTH. Stare and blink, no post-ictal fatigue or sleep. EEG is 3 hertz. The onset between 4 to 8 years of age is absence seizure. The treatment of choice, to remind you, is ethosuxamide. Seizure during sleep associated with facial twitching and drooling. The onset between 3 and 10 years of age. The diagnosis is benign Rolandic epilepsy. So the key here, seizure during sleep is Rolandic. During sleep is Rolandic and spontaneously remit and require reassurance. Seizure in the morning, new onset during adolescence. The EEG is 4 to 6. So the EEG here, the speed is high, and in older children, so high and high. And it is polyspike, it is juvenile myoclonic epilepsy, and the treatment here is for life. And remember, to remind you, the treatment of choice is valproic acid for the pediatric board purpose. Language regression or aphasia after normal language development plus EEG changes is Landau-Kleffner syndrome or acquired epileptic aphasia. Intractable seizure, difficult to treat. Intellectual disability or a slow child with a slow wave EEG, 2 Hz, is Lennox-Gastaut syndrome. Progressive partial seizure, difficult to treat, positive antibodies, atrophic hemisphere, Rasmussen's encephalitis. Infant with sudden burst of laugh, cooing, giggling, smiling, associated with hypothalamic hamartoma is gelastic seizure. For the EEG difference, the absent seizure is 3 Hz. Juvenile myoclonic, older children, is 4 to 6 Hz. Slow children with intractable seizure, 2 Hz EEG, is Lennox-Gastaut syndrome. Type of seizure and the treatment of choice. Partial seizure, carbamazepine, oxcarbazepine, phenytoin. Absent seizure, ethosuxamide. Generalized seizure, valproic acid, phenytoin. Infantile spasm, ACTH and vigabatrin in cases of tuberous sclerosis. Anti-epileptic drugs and the common side effects. Ethosuxamide, GI upset, for example nausea, abdominal pain, leukopenia, liver dysfunction. Carbamazepine can cause rash, in severe cases Stevens-Johnson syndrome. Drug interaction, for example, this will decrease the efficacy of oral contraceptive pills and the medication will lose the contraceptive effect. SIADH, leukopenia, hepatotoxicity, teratogenicity. Phenytoin associated with zero order kinetics, which is the rate of the elimination is constant. So if you give a higher dose, the rate of elimination will stay the same, and this may cause phenytoin toxicity and by itself can cause seizure, hirsutism, ataxia, gum hypertrophy, rash, teratogenic effect, fetal hydantoin syndrome. Phenobarbital commonly used in neonates and infants and can cause cognitive slowing. This is important, and behavioral changes. Lamotrigine rash, in severe cases Stevens-Johnson syndrome. All anti-epileptic drugs, they have this risk of suicidal ideation. Very important for consultation with parents when you start this type of medications. Conditions looks like epilepsy or epilepsy mimics but is not epilepsy. And the first one is breath holding spells is common. Typical age is between 6 to 18 months. There is 2 types: cyanotic breath holding spells triggered by emotional stimuli like anger and frustration, and the breath holding occurs in expiration. Pallid breath holding episodes provoked by sudden fear after injury or surprise. Characteristics of breath holding spells: loss of consciousness followed by lameness, which can be associated with movements like jerk movements or tonic posturing, and because of brief cerebral ischemia. Usually last less than a minute. By age of 4, most of the children will grow out of breath holding spells. Laboratory: if you suspect iron deficiency anemia, CBC and iron level will be appropriate. Management: you treat associated iron deficiency anemia if any. Behavioral modification, and the parents should ignore the child or ignore this behavior, but also they have to make sure the safety of the environment around the child and keep their eyes on the child. Sandifer syndrome is tonic neck extension and tonic posturing of the trunk, commonly associated with GERD. Posturing is believed to be because of the reflux. Normal neurological examination, treatment of GERD will solve this problem in most of the cases. Syncope can look like epilepsy but is not. It is a brief loss of consciousness as well as postural tone. It is really common in adolescents. It is because of transient decrease in cerebral perfusion with rapid recovery back to baseline. The most common cause is neurocardiogenic or vasovagal. Red flags, which is not vasovagal: syncope during exercise. You should look for cardiac origin causes, for example supraventricular tachycardia, prolonged QT, or a structural cardiac problem like aortic stenosis. Recurrent syncope is not normal. Family history of syncope or sudden unexplained death in the family. This is just a reminder: all children present with new onset partial seizure must have brain imaging studies to rule out brain tumor. No anti-epileptic medications for the first episode of seizure in the most of the cases. MRI is the study of choice for spinal cord even in acute events or cases. Touch paralysis is a weakness or paresis can occur after partial seizure and is self-limiting and require reassurance and rest until the weakness disappears. We'll start a new subject: headaches. Types of headaches: migraine headache, tension headache, chronic non-progressive headache, and chronic progressive headache. We'll start with migraine headache. The clinical presentation of migraine headache: acute intermittent headache, comes and goes. The duration of pain varies, can be as little as 30 to 60 minutes, up to 72 hours or even longer. The headache can be located bilaterally or unilaterally, so it's not necessary to be unilateral, as it is well known. Typically has a pulsating pattern, may be associated with nausea and vomiting, photosensitivity or light sensitivity and sound sensitivity, and vertigo. Migraine can be associated with aura, and I will explain that in the next slide. A child typically seek quiet and dark room or dark area to rest. Sleep often relieve the pain. Also, you have to know that younger children may present with cyclic vomiting or a benign paroxysmal vertigo. Then eventually they will end up with typical migraine as they get older. Features of aura or prodrome: fully reversible visual symptoms, flickering lights, spots, lines, and even loss of vision. Fully reversible sensory symptoms like pins and needles or numbness. Fully reversible dysphasic speech disturbance. Tension headache is a mild form of headache, is less disabling than migraine. Migraine can be associated even with hemiplegia. Usually there is no nausea or vomiting, can have either photophobia or phonophobia, but usually do not have both together. Pain often described as band-like. This is the key word for tension headache for the pediatric board exam, and clinically is band-like. Often responsive to over-the-counter medication, for example, ibuprofen. Chronic non-progressive headache is also called daily persistent headache. The definition of chronic non-progressive headache is headache persistent more than or equal 4 months, more than or equal 15 days per month. Common in adolescence. Usually there is no abnormalities in the exam, so the neurological examination is normal, and often there are psychosocial factors involved like stress. Chronic progressive headache, this is the one you don't want to miss when a child presents with headache because require intervention. Gradual increase in frequency of the headache and severity. So think about increased intracranial pressure or causes of increased intracranial pressure. The first one you don't want to miss at all is brain tumor, hydrocephalus, chronic meningitis, brain abscess, subdural hematoma, idiopathic intracranial hypertension, which is well known as pseudotumor cerebri. Headache red flags. This means this will require immediate intervention in the imaging study. Sudden severe headache is not normal. Sudden severe headache or the worst headache in my life. This is a clue. Occipital headache or neck pain. Neck pain never normal in children. Neck pain never normal in children, has to be taken seriously. Early morning headache or early morning vomiting and nausea. Pain that awakens the child from sleep. Worsening of pain with a change in position or sneezing or coughing. Increased frequency and intensity of the headache. A change in mental status is a red flag. Cranial nerve pulses, visual field defects, papilledema, abnormal papillary response, focal neurological deficit, ataxia, gait disturbance. General ideas for treatment of primary headache syndrome: lifestyle modifications, regular meals, consistent sleep, exercise, hydration. Methods to cope with stress, especially for adolescents in high school, for example. Treat pain early. Also advise the patient not to overuse or the excessive use of analgesic like ibuprofen, because by itself it can cause analgesic headache. Set realistic goals. Treatment of primary headache syndrome including migraine. Acute treatment: ibuprofen. Ibuprofen is the best answer and always the correct answer for migraine headache for acute treatment. Acetaminophen also is another option, especially if the child has a stomach problem or gastritis. Triptan only, rizatriptan and almotriptan are FDA approved for pediatrics. Chronic treatment or prophylactic treatment of headache: try to use medication will address comorbidities, means that will solve other problem with it. For example, amitriptyline is not a good choice for obese children because it will cause increase or weight gain. But is a good choice for children with a sleep problem because will help them to sleep. Topiramate is a good option on the other hand for obese children because may cause weight loss. But you need to be careful if the patient have or is having history of kidney stones or family history of kidney stones. Topiramate, one of the best medication to be used for prophylaxis for migraine headache. Avoid propranolol in the patient with asthma. Alternative therapies, behavioral therapies, biofeedback and relaxation exercise, acupuncture, natural supplements like vitamin, for example, magnesium and riboflavin. Idiopathic intracranial hypertension, it is well known as pseudotumor cerebri. It is an important diagnosis to consider in the differential diagnosis in the patients presents with chronic daily headache. The incidence is 3.5 to 19 per 100,000. It is more common in females. Red flags and possibility of idiopathic intracranial hypertension. There is many case scenarios in this slide. Female with obesity presents with a daily headache and a progressive headache. You should consider pseudotumor cerebri neurodifferential. Also, female with dysmenorrhea or with acne and is taking oral contraceptive pills and is presenting with daily headache, you should consider pseudotumor cerebri neurodifferential. Also, patient taking tetracycline for acne and presents with headache, you should consider also this diagnosis. Penicillin, nalidixic acid. Patient presents also with acne and is taking retinoic acid for acne, for treatment of acne. You should consider pseudotumor cerebri in the differential. Short stature, for example, and is taking growth hormone therapy, presents with headache or daily headache or progressive headache. This is one of your differential, or is important to consider it. Vitamin A in the children in amount exceeds 100,000 units per day is a risk factor for idiopathic intracranial hypertension. Patients with chronic UTI or severe degree of reflux and is taking prophylaxis with Bactrim on daily basis and presents with headache and a chronic progressive headache, you should consider Bactrim is the cause or possible cause of headache and possibility of idiopathic intracranial hypertension. So this, you can get a lot of case scenarios, a lot of clinical presentation from this slide. Clinical presentation of pseudotumor cerebri headaches. This is the most important presentation. Headaches and often will have diffuse pounding headache and is non-specific. Neck stiffness and neck pain. So neck stiffness and neck pain or any neck complaint must be taken seriously in children. I cannot emphasize more than that on the neck problem in children. Has to be taken seriously. Papilledema and visual field. Transient visual disturbance lasts up to 30 seconds, progressive loss of peripheral vision, sudden vision loss, and this is possibility of intraocular hemorrhage. Limited abduction of one of both eyes because of sixth cranial nerve palsy or paresis or abducing nerve. Neuroimaging is often normal. Diagnosis or diagnostic approach to cases of pseudotumor cerebri. CT scan or MRI is step number 1 and it should be normal. And if it is normal, you will go ahead with the lumbar puncture for CSF evaluation, and you will see the high opening pressure in the cases of pseudotumor cerebri during the lumbar puncture. The lumbar puncture actually can be also therapeutic because it will relieve the pressure. Treatment of pseudotumor cerebri, avoid triggering agents. For example, if the patient is taking tetracycline or retinoic acid or contraceptive pills for acne, you stop this medication and choose other alternatives. Weight loss in females or patients with obesity. Carbonic anhydrase inhibitors, acetazolamide, will lower the intracranial pressure. For the eye, ophthalmological follow-up is very important, and in severe cases they may require surgery and immediate consultation, like if the patient complaining of a visual field defect or vision loss or possibility of intraocular hemorrhage. Neurocutaneous syndrome. There is a strong relationship between the nerves and skin because both they develop from the same germ layer embryologically after conception. The first thing develop from the ectoderm, the spine, peripheral nerves and the brain. Skin, the epidermis or the outer layer, and also tooth enamels, the lining of the mouth, nostrils and the anus. So there is a strong association between defects or any problem with the skin and nerve. So that's why we have neurocutaneous syndromes. First and most important neurocutaneous syndrome, we need to know it by heart, is neurofibromatosis type 1. It is autosomal dominant. Very important to remember the chromosomes, chromosome 17. This is the most common. The incidence is 1 in 3,000 and onset in a childhood. Diagnosis of neurofibromatosis type 1, 2 or more of the following: 6 or more cafe au lait spots, 5 mm in diameter in prepubertal and 15 mm in diameter in pubertal children. Axillary or inguinal freckling, this appears early in childhood. 2 or more lesh nodules in the iris, this appears in children more than 6 years of age. 2 or more neurofibromas or 1 plexiform neurofibroma. Distinctive bony lesion is sphenoid dysplasia, thinning of long bone of the cortex, pseudoarthrosis. Optic glioma appears in children less than 6 years of age, first degree relative with neurofibromatosis type 1. Common associated problem with neurofibromatosis type 1: learning disabilities, migraines, visual impairment, seizures, scoliosis, sphenoidal dysplasia, bow tibia, or pseudoarthrosis. Like in this x-ray, this is a lateral view showing the pseudoarthrosis or false joint with thinning and atrophy of the tibia. And also here the fibula is affected as well, and also they present with short stature. Very important to know that neurofibromatosis type 1 increase the risk of brain tumor. So any child with neurofibromatosis type 1 presents with headache, it should be taken seriously. So know this risk factor: neurofibromatosis type 1 increase the risk of brain tumor, astrocytoma. Meningioma and leukemia also associated increased risk. Management is genetic counseling, early detection of malignancies, prevention of future complications. Neurofibromatosis type 2 is autosomal dominant. The chromosome is 22. The type 1 is 17, but type 2 is 22. Type 2 is 22, and the incidence is more rare, is 1 in 40,000. So it's more rare than type 1. The onset in adolescence, if you compare it to type 1 appears early, and type 2 appears later in life. So it's easy to remember. Diagnosis of neurofibromatosis type 2 made by one of the following: bilateral vestibular schwannoma or a tumor of the cranial nerve number 8, first degree relative with neurofibromatosis type 2, unilateral vestibular schwannoma, or any two of the following: meningioma, schwannoma, neurofibroma, glioma, subcapsular cataracts. Clinical presentation: hearing loss, tinnitus, gait abnormalities, associated risk, multiple inherited schwannoma, meningioma, and ependymoma or brain tumor. Management: genetic counseling, annual hearing screen, and early detection of malignancies. Tuberous sclerosis, this is another neurocutaneous syndrome, autosomal dominant. The chromosome is 9 or 16. The incidence is 1 in 6,000 live births. 50% is very important to know that 50% may be spontaneous mutations. Major features of tuberous sclerosis: ash leaf spots, which is hypopigmentation on the skin, and this can be seen easily after birth. Chagrin patch, which is a connective tissue hamartoma, commonly seen in the lower back and is a leathery texture, so it's a little bit soft. Periangual fibroma, which is similar to the fibroma around the nose, but you will see it around the nails. Facial angiofibromas, which is similar to the acne but does not respond to the acne medicine and the clusters around the nose. Cardiac rhabdomyoma, renal pulmonary angiomyolipomas, cortical tubers, and subependymal giant cell astrocytomas, and this can present with obstructive hydrocephalus. Clinical symptoms, very important to know about tuberous sclerosis because it can be missed. The presentation can be just seizure, but in this case you need to look, any child present with seizure, you need to look careful in the skin for any skin lesions. So seizures, the most common presentation of tuberous sclerosis: learning disabilities, intellectual disability, infantile spasm, autism. So autistic children, they may have tuberous sclerosis. You should keep that in your differential. ADHD, obsessive compulsive disorder. So these one of the things you can miss the tuberous sclerosis. You should consider it in your differential for children with autism, ADHD, and obsessive compulsive disorders. Management of tuberous sclerosis: seizure control, echocardiogram screening for cardiac rhabdomyomas, blood pressure check, renal ultrasound screening for renal angiomyolipomas, and neuroimaging study for cortical tubers and astrocytomas. This is a 9-month-old with facial port wine stains. It presents with glaucoma and seizure. What is the most likely diagnosis? This is a classic presentation of Sturge-Weber syndrome. The mode of transmission of Sturge-Weber syndrome is a spontaneous mutation or sporadic. Neurofibromatosis and tuberous sclerosis are autosomal dominant, but Sturge-Weber syndrome is sporadic. Most patients with port-wine stain do not have Sturge-Weber syndrome. The incidence only 8 to 15% for the patient with port-wine stain to have Sturge-Weber syndrome, but majority do not have Sturge-Weber syndrome. This is important. Clinical features: facial port-wine stain in V1, 2, or even 3 distribution of the trigeminal nerve. Glaucoma is very important, and this may appear even after birth. Seizures: ipsilateral cerebral leptomeningeal angioma, which is calcifies over time and can cause a tram track railroad calcification in the CT scan. Common associations with Sturge-Weber syndrome is a developmental delay, intellectual disability, learning disability, ADHD, contralateral hemiparesis, soft tissue hypertrophy, hemianopia. Management of Sturge-Weber syndrome: initial ophthalmic evaluation should be started after birth. Annual eye screening for life. It is very important to have annual eye screening, monitoring for the intraocular pressure. Any child presents with ocular pain and visual disturbance should have urgent referral and immediate referral to ophthalmology. Seizure control may require hemispherectomy, which is their seizure very difficult to control. Treatment of port-wine stain on the face with tunable laser dye should be offered because this can be stressful to the child and the family as well. New section with brain malformations. Neural tube defects. Anterior neural tube defects is anencephaly and encephalocele. Any woman in a childbearing period should start folic acid, because by the time the woman will know she is pregnant, the neural tube is already formed. So very important to give 0.4 milligram per day or to 0.8 milligram per day before conception. The key here is before pregnancy, or a 4 milligram higher dose per day if previously affected. Anencephaly. Anencephaly is failure of anterior neural tube closure. So you will see a big portion of the brain is missing. Mostly die after birth. Association eye face malformation, hypoplastic pituitary gland. Prenatal screening, this may be detected prenatally with a high alpha fetoprotein and also with ultrasound. Encephalocele is a neural tube defect, is a sac-like protrusion of the brain covered with membranes. Clinical presentation: hydrocephalus, spastic quadriplegia, ataxia. The diagnosis: ultrasound prenatally and elevated alpha fetoprotein. This table is to summarize the difference between Arnold-Chiari malformation type 1 and type 2. Type 1 is herniation of cerebral tonsils more than a half a centimeter below the foramen magnum into the cervical canal. Type 2, similar, cerebral herniation of cerebral tonsils with more structure, lower medulla, pons, fourth ventricle through the foramen magnum into the upper cervical canal. Type 1 is the most common and least severe, so please correct that in the pediatric board study guide. Type 1 is the most common, not type 2. Type 2 is less common and more severe. Type 1 can be associated with syringomyelia. Type 2 usually associated with hydrocephalus and myelomeningocele. Type 1 is asymptomatic during childhood and most of the cases, and can be found incidental in brain MRI done for other reason. During adolescence, the child may present with neck pain, so neck pain should be taken seriously all the time in children. Recurrent headaches, sleep apnea, bowel, bladder dysfunction, lower extremity spasticity. Type 2, because it's more severe, may present during infancy, and the infant may present with dysphagia, apnea, weak cry. Older children may present with gait abnormalities. Type 1 usually require observation and follow-up surgical decompression if symptomatic or if is necessary. Type 2 require observation, serial MRI follow-up, and surgical decompression is required in most of the cases because of the complications. Less encephaly or smooth brain without sulci. This can be associated with Miller-Dieker syndrome. Miller-Dieker syndrome is less encephaly, prominent forehead, mid-face hypoplegia, small upturned nose, low sit and abnormally shaped ears, small jaw and thick upper lip. Just a reminder with Miller-Dieker syndrome. Clinical presentation of less encephaly, microcephaly, neurological impairment, and seizures. Diagnosis and treatment CT or MRI of the brain and supportive care. Holoprosencephalon or encephaly is a defect of development of prosencephalon, so the brain failed to form two cerebral hemisphere, so will form only one hemisphere, and usually associated with midline defect or facial defect like cleft lip, fused nostrils, just one single nostril, single central incisors, and also they may have one eye only, cyclopia, just born with one single eye in the middle. These children usually die before or soon after birth. Polymicrogyria, from the name, it's a presence of large number of gyral convolutions separated by shallow sulci. This is usually an acquired defect. The presentation depends on the location and the severity. They commonly present with seizure. The diagnosis is CT or MRI, and the treatment is supportive. Agenesis of corpus callosum, from the name, it's a complete or partial absence of corpus callosum. This can be isolated condition and also found incidentally on head imaging study done for other reason. When accompanied with other malformation, can result in severe seizure and intellectual disability. This is complete absence of corpus callosum, and this is partial absence of corpus callosum. Should be circling like this. This part is missing. Common associations with corpus callosum: chromosomal mutation 8, 9, 13, and 18. Inborn errors of metabolism, for example, non-ketotic hyperglycemia, neonatal adrenoleukodystrophy, pyruvate dehydrogenase deficiency, teratogenes is common, and this common in the board. Pay attention to it. Cocaine use, maternal cocaine use. Clinical presentation of agenesis of corpus callosum asymptomatic. This is the most common presentation. Many people, they are living out there and they do not have corpus callosum, and they are living their normal life with no symptoms, and most of the time it is found incidentally for MRI or imaging study done for other reason. They may present with intellectual disability, seizures, hypo or hypertolerism. Very important to know this syndrome, Aicardi syndrome, is associated with agenesis of corpus callosum. Aicardi syndrome is X-linked dominant or X-linked dominant, affects only girls, associated with agenesis of corpus callosum. Chorioretinal lacunae. Chorioretinal lacunae is bilateral optic nerve coloboma, associated with pale areas on the retina of different size, or also we call it loci, and commonly located in the nasal aspect of the optic disc. Chorioretinal lacunae and infantile spasm. So again, Aicardi syndrome is X-linked dominant, agenesis of corpus callosum, chorioretinal lacunae or retinal defect, and infantile spasm. So again, very important for all the children with agenesis of corpus callosum to have eye exam. These children also may present with recurrent hypothermia. Developmentally, they are normal if it is only neurologic manifestation, not associated with other syndrome. Diagnosis and the treatment: MRI of the brain, supportive care, treatment of neurologic complications. Dandy-Walker malformation is a cystic expansion of fourth ventricle in the posterior fossa. Cystic expansion of the fourth ventricle in the posterior fossa. Common associations: hydrocephalus. This is the most common association with Dandy-Walker malformation. Agenesis of corpus callosum, agenesis or hypoplegia of cerebellar vermis, orofacial deformities, congenital, cerebrovascular, gastrointestinal, genitourinary system abnormalities. Symptoms and diagnosis. To remind you, Dandy-Walker malformation commonly associated with hydrocephalus. So rapid increase in head circumference is a red flag. Prominent occiput due to hydrocephalus, cerebellar ataxia, delayed motor and cognitive development. The diagnosis and the treatment: MRI of the brain will show the cystic structure in the posterior fossa. VP shunt for the hydrocephalus and the treatment of neurologic complications. Disorders of head growth. Microcephaly is head circumference more than 2 standard deviation below the mean for age and gender. Causes: primary and secondary. Primary is genetic syndromes, chromosomal abnormalities, for example trisomy 13, 18, and 21. Acquired intraurinary infection, torch infection, especially cytomegaloviral infection, postnatal infections, meningitis, encephalitis, hypoxic ischemic encephalopathy, stroke, traumatic brain injury, and malnutrition. Diagnosis of microcephaly: ask about family history, obtain torch titer, consider karyotype, neuroimaging, treatment, genetic counseling, monitor for developmental delay, refer for appropriate interventions such as physical, occupational, and speech therapy, ECI. Macrocephaly is a head circumference more than 2 standard deviation above the mean for age and gender. Megalocephaly means large brain. Etiology: familial, very important to look at the parent. Sporadic, associated with neurofibromatosis, tuberous sclerosis, and achondroplasia. Certain metabolic disorder, like for example Alexander's syndrome, Canavan disease, and Soto syndrome. This is important. Diagnosis of macrocephaly: ask about family history, look at the head size of the parents, check for evidence of increased intracranial pressure. If any concern about intracranial pressure, you need to do imaging study. Treatment: treat the underlying etiology, monitor development, and refer to appropriate service if is indicated. Hydrocephalus. Hydrocephalus is disturbance of formation, flow, or absorption of cerebrospinal fluid. This leads to increase in volume within the cerebral ventricles and elevation of the intracranial pressure. This diagram to simplify the circulation of CSF in the central nervous system. The CSF flow from the lateral ventricles to the third ventricles via foramen of Monro, and from the third ventricle to the fourth ventricle via aqueduct of Sylvius, and from the fourth ventricle through the foramina of Loschka and foramina of Magendie to the cisterna magna, from the cisterna magna to the subarachnoid space in the brain and spinal cord, and the CSF will be absorbed in this place in the arachnoid granulations, and from the arachnoid granulations to the venous sinus blood. Any obstruction within the system can cause obstructive hydrocephalus. The classic example is stenosis of aqueduct of Sylvius. So any obstruction within the system will cause obstructive hydrocephalus. Anything affects the arachnoid granulations, for example subarachnoid hemorrhage or meningitis, will interfere with the absorption and will cause non-obstructive hydrocephalus. The classic example: subarachnoid hemorrhage and meningitis. This table to summarize the difference between obstructive and non-obstructive hydrocephalus. Obstructive hydrocephalus is well known as non-communicating hydrocephalus as well. Non-communicating hydrocephalus means that there is obstruction within the system, the obstruction of outlets to the arachnoid granulations. But the non-obstructive type, there is a communication, there is no problem within the system, so the system is communicating, but the obstruction is outside the system, so the cisterns and the arachnoid villi cannot absorb the CSF. Why? Commonly because of accumulation of blood or infectious material. The common causes of that: subarachnoid hemorrhage, intraventricular hemorrhage like in preterm infants, and meningitis. A common etiology of obstructive hydrocephalus is congenital aqueductal stenosis. Other causes like a mass, for example posterior fossa tumor, Arnold-Chiari type 2, and Dandy-Walker syndrome. Clinical presentation of hydrocephalus in infants: because of the fontanelles are open, you will see full fontanelle in cases of hydrocephalus. And because the fontanelles are open, usually they do not have papilledema because still there is a room to grow. So full fontanelle, rapid hair growth. So you should pay a careful attention to any preterm infants presents in the clinic for well visit, and when you measure the head circumference. Any crossing percentile is a red flag for hydrocephalus. Wide sutures, poor feeding, downward deviation of the eye, and you can ask the patient to look up. Inability to look up is a red flag for hydrocephalus. Older children with hydrocephalus, they will present with signs of increased intracranial pressure. The first and most important is headache, and the headache is positional early in the morning, may be associated with nausea and morning effortless vomiting and projectile. Papilledema, which is swelling and blurring of the optic disc margin. And this is important. They put it in the pediatric board most of the time to give you a hint for signs of increased intracranial pressure, diplopia or double vision, 6 cranial nerve palsy or ability to look to the side because of paresis or paralysis of abducens nerve, increased head circumference, increased muscle tone, and or exaggerated reflexes. Very important to know the Cushing triad, which is a late sign of increased intracranial pressure or severe cases of increased intracranial pressure. This is a really bad sign to have, which is bradycardia, hypertension, and irregular breathing, and this is require immediate intervention and admission to the ICU. Diagnosis of hydrocephalus: consider head ultrasound in infants through the anterior fontanelle. It is safe and no radiation, and is diagnostic in most of the cases. Head CT or MRI in older children, or if the ultrasound is non-conclusive. Treatment, if possible, treat the underlying etiology. Medical treatment with acetazolamide. Definitive treatment is surgical with placement of ventriculoperitoneal shunt. Complications of ventriculoperitoneal shunt or VP shunts, very important to note, because the patient may present initially to the pediatrician with these complications. Obstruction. So diagnosis in infants, you can use the ultrasound, is very helpful. In older children or in absence of sonographic window, CT scan is the best. Infection associated with VP shunt, the most common bacteria you need to remember is Staph epidermis. This is the most common. Also Staph aureus can cause that. What is craniosynostosis? Craniosynostosis is premature fusion of one or more sutures, and this will cause abnormal skull shape. The incidence is about 3.4 per 10,000 births. The most common is premature closure of sagittal suture. So the premature closure of the sagittal suture is the most common type of craniosynostosis. Etiology of craniosynostosis: typically sporadic. Secondary causes you should consider: certain metabolic disorder like hyperthyroidism, storage disease like mucopolysaccharidosis, genetic disease like Krausen or Apert or Pfeiffer syndrome, hematological disorder like thalassemia, brain malformation like holoprosencephaly, microcephaly, teratogene exposure, valproic acid. Diagnosis of craniosynostosis: clinically from the shape of the skull and palpation of the skull, feeling the prominent sutures, skull film, which is really sufficient before referring the child to the neurosurgeon. No need to order CT scan because of radiation, and most of the surgeon now they do the surgery without a CT scan. So leave it for the surgeon. If the surgeon need the CT scan, they will order it to avoid unnecessary radiation to the child. Treatment is surgery in moderate to severe cases. Usually they perform the surgery to restore the normal skull facial growth and development, and this is typically between 3 to 6 months. Surgical intervention is mandatory and immediately if there is any signs of increased intracranial pressure. Vascular anomalies. The first complication of vascular anomalies is a stroke. The incidence of stroke in children is about 2 to 3 per 100,000 children annually. Is about 1 in 4,000 live births in infants. The causes: vasculopathies. The most common cause is arterial dissection. This is the most common cause in pediatric, arterial dissection, when they do straining exercise or sudden movements. Ischemic stroke, congenital heart disease, coagulation disorders, infections, meningitis, sickle cell anemia. Example of hemorrhagic stroke: congenital vascular malformation like AV malformation, brain tumors, head trauma, and thrombocytopenia. High index of suspicion must be maintained to be able to diagnose early stroke in children, because they take too much time comparing to the adult to have the classic presentation. They take up to 2 days comparing to the adult when they present very early in the first 30 minutes. Acute onset of hemiparesis or weakness on one side of the body is classic. Seizures can be the presentation, so you should keep stroke in your differential when a child presents with a new onset seizure. Severe headache with focal neurological symptoms, or if the child say, "This is the worst headache of my life," this is a clue for you. Stiff neck, nausea, vomiting, this is can be a sign of subarachnoid hemorrhage. Additional signs and symptoms, which is really non-specific, like irritability, lethargy, behavioral changes. So it's non-specific, so you should keep always a stroke in your differential when a child presents with any of these symptoms. Moya moya in Japanese language means a puff of smoke. This came from the description of the blood vessels on the MRA or angiography. The two tools you are able to diagnose moya moya is MRA and angiography. So the shape, the way the blood vessels will look like a puff of smoke with sudden interruption in one of the blood vessels that feeds the circle of Willis. So this is a progressive and occlusive disease of cerebral vasculature or cerebral blood vessels, specifically circle of Willis and the arteries that feed it. For example, internal carotid artery, anterior or middle cerebral artery. So you will see interruption or stenosis or occlusion of these arteries when you do the angiography or the MRA. Associations or common associations with moya moya, sickle cell disease. This is the most common cause in pediatrics. Other causes like Graves' disease, neurofibromatosis, Down syndrome. Clinical presentation, stroke, and this is you can review that in the previous slide. Arteriovenous malformation is failure of normal capillary bed development between the cerebral arteries and the veins. Most cases are sporadic and isolated. Causes supratentorial intracranial hemorrhage. Clinical presentation if the hemorrhage occur, if the AV malformation bleeds occur. If it doesn't occur, they can be living asymptomatic with no problem. They present if they bleed with sudden headache, seizure, focal neurological deficits. Diagnosis of arteriovenous malformation always when complication occur, for example seizure or bleed, intracranial bleed. For the intracranial bleed, the best study to show the blood is the CT scan for acute bleeding, and for a diagnosis of the detailed anatomy of the AV malformation is conventional angiography or MRA. Management surgical treatment is often required. Vein of Guillain malformation is arteriovenous shunt between cerebral arteries and the vein of Guillain. Clinical presentation typically presents in the neonatal period with high output congestive heart failure. Progressive macrocephaly from the hydrocephalus because of increased venous pressure. Diagnosis of vein of Guillain malformation, neuroimaging, treatment, management of congestive heart failure, and the embolization to close the shunt. Cerebral venous thrombosis, highest risk is during the neonatal period, causes infection, especially infections involving the head and the neck, for example sinusitis, mastoiditis, meningitis, dehydration, especially hypernatremic dehydration, perinatal events, prothrombotic disorders or coagulation disorders, head trauma, malignancy, cardiac diseases, chronic systemic diseases. Clinical presentation of cerebral venous thrombosis, diffuse neurologic deficit or focal deficit, seizures, headache, lethargy, nausea, vomiting, signs of increased intracranial pressure. Diagnosis of cerebral venous thrombosis needs venous imaging, and the imaging goal is to assess the blood flow and filling defects. The MRI and the MRV is the magnetic resonance venography, is often the modality of choice because of lack of radiation. Treatment, anticoagulation, therapy, treatment of the underlying cause. Epidural hemorrhage. Epidural hemorrhage means bleeding between the dura and the skull. The blood vessels involved is the most commonly arterial and the middle meningeal artery specifically, and this is commonly associated with temporal skull fracture. In children also can occur from the venous bleeding and is not always associated with the skull fracture. On CT scan you will see a convex lens-shaped hyperdensity. Emergency surgical consult. So any child with suspected epidural hemorrhage, you should have emergency surgical consult. This can save life. Surgical removal of hematoma requires to prevent further injury and herniation of the brain. If managed in a timely manner, recovery in children is often good. Adverse effects are secondary to rapid enlargement of the hematoma because it's arterial, just continue bleeding. Subdural hemorrhage is bleeding under the dura, beneath the dura, under the dura. This results from the venous blood, is from the tearing of bridging veins. So it's venous. Dural is venous and epidural is arterial usually. Causes, the most common cause is intracranial birth injury and obstetric complication. This is the most common cause. Also can be caused by bacterial meningitis and non-accidental trauma. So child abuse should be suspected in a child or infant present with subdural hemorrhage. On CT scan you will see a crescent-shaped hyperdensity. Crescent-shaped hyperdensity, and usually associated with cerebral edema and shift to the opposite side, shift of the brain structure to the opposite side. As you see here, there is a shift of the structure. This side is much bigger than this side. Focal cerebral edema and midline shift, as we saw in the CT scan in the previous slide, can cause herniation, and also the patient may present with progressive focal neurologic deficit. The management, more aggressive management if there is extensive edema and signs of increased intracranial pressure. Surgical removal of hematoma is necessary, especially in symptomatic cases. Subarachnoid hemorrhage. Common causes: traumatic brain injury, neonatal injury resulting from a tearing of veins that cross the subarachnoid space. In infants, clinical presentation: irritability, is non-specific irritability, lethargy, poor feeding, and seizure. We'll start with the new section: concussion. Head concussion. What is head concussion? It is very important to keep the definition of head concussion clear in our mind. It is alteration in neurologic function or mental status after head injury that may or may not involve loss of consciousness. So it could be associated with or without loss of consciousness. It is rapid onset of impairment of neurologic function. It is short-lived and resolves spontaneously. It is caused by trauma directly to the head or the body. So the body may shake and affect the head. So the trauma can be directly to the head or to the body. And normal imaging studies, so no intracranial bleed. So if there is intracranial bleed, we cannot call it head concussion. Clinical features of head concussion: the patient may complain of headache, dizziness, vomiting, amnesia, confusion. Patient typically improve over minutes to few hours. Failure to improve or worsening symptoms are indication for imaging, and if it is not performed previously. What is the indication for a head imaging study? Of course, if you suspect any intracranial pathology, generally, specifically if the Galaxo Coma scale less than or equal 14 or persistent altered mental status, focal neurologic abnormalities, skull fracture, prolonged loss of consciousness, post-traumatic amnesia, clinical deterioration. Important questions for any child with head concussion when to return to play. First step, or the most important thing, the patient has to be asymptomatic and off medication. Asymptomatic and no medication. And when in doubt, always stay out. When in doubt, stay out to be safe. Gradual return to play is important. Each stage should last for no less than 24 hours. Total 5 to 7 days from the onset of concussion, minimum 5 days. First stage, no activity, which is day 1 after concussion. Then day 2, a light aerobic activity, walking, swimming, sport-specific exercise. Then the next, non-contact light resistance, full contact, then eventually return to play. So remember, minimum 5 days from the onset of concussion to be able to go back to play, and also asymptomatic and off medications. Skull fracture, linear skull fracture is the most common. No treatment is necessary. Very important to keep in mind, non-accidental trauma should be explored. Spinal cord diseases. Tethered cord is very important. Distal part of the spinal cord is thickened and anchored into the spinal canal. As the child grows, the distal part of the spinal cord is stretched and can become ischemic and develop symptoms. Tethered cord clinical features: the red flag cutaneous lesion in the lower back, like a tuft of hair, dimple, hemangioma, lipoma. This is a red flag for possible underlying tethered cord. Lower extremity weakness, spasticity, numbness. This is the preclinical presentation. Scoliosis, lower back pain. So it's important to keep that in mind. So by examining the back, any child have any back complaint or any weakness in the lower extremities, spasticity, you have to examine the back. Diagnosis of tethered cord is MRI. MRI is the best study to show the soft tissue in the spine. Treatment is surgery, transection of the filum terminal. Prognosis, neurologic deficit are often irreversible. So early diagnosis is important. Spina bifida occulta. Spina bifida occulta, this is the mildest form of spina bifida. The spinal film will show incomplete closure of some vertebrae. May see midline sacral tuft of hair or dimple on the exam. It is commonly between L5 and S1. No neurological symptom can be associated with syringomyelia. Very important to keep that in mind. Tethered cord or dermoid sinus connecting skin to the meninges, and this can be a chance for infection to cause meningitis. So if you see a child with meningitis, especially E. coli, and you should examine the back carefully, could be a sinus there. Often there is no need for intervention in these cases. This is the spina bifida occulta, and you can see the tuft of hair and the defect in the spine. Meningocele is a protrusion of meninges from the back by itself without nervous tissue. So protrusion of the meninges without nervous tissue. The risk is 10% if previous to affected, 4% if subsequent sibling affected, 1 to 2% valproic acid exposure during pregnancy. These risk factors are important to keep in mind. Typically will not have neurological symptoms. MRI is the study of choice. And the treatment is surgical closure of the back. Prevention, again to emphasize, before conception 0.4 milligram per day to 0.8 milligram per day before conception, 4 milligram if previously affected. Myelomeningocele, from the name myelo means the nerve and meningo means the meninges, and cele is the protrusion. So this is a protrusion of the meninges with the nerve with it. So the nerve is included in myelomeningocele. These children, they will have normal intelligence, they can go to college, they are very smart, and there is no problem with the brain function. They will have neurological deficit, and the neurological deficit will depend on the level of the spinal cord involvement. Of course, the higher the worse and the lower the better. Bladder and bowel dysfunction is common. Decreased reflexes, clubfoot is a common association, hip subluxation. Myelomeningocele association, also hydrocephalus, is about 80 to 85%. You have to keep that in mind. This may develop over time, more common when the lesion is in the thoracolumbar area. Again, the higher the worse. And Chiari to malformation also can be associated with myelomeningocele. The treatment, consult neurosurgery. This is considered a neurological emergency. Head MRI is very important, and supportive care placement of VP shunt if hydrocephalus develop, and orthopedic referral is very important, or consultation. Transverse myelitis. It is inflammation of the spinal cord, typically involving less than or equal 3 vertebral segments, and including both motor and sensory abnormalities. Causes post-infectious or post-vaccination viral myelitis, autoimmune vasculitis, spinal cord trauma. Clinical presentation is back pain around the involved spinal segment. Back pain is the key for the diagnosis of transverse myelitis and the associated symptoms or neurological symptom, back pain and tenderness. Thoracic cord is the most commonly affected, weakness, and the paralysis is often flaccid. Irreflexia initially, then followed by spasticity and hyperreflexia. Sensory level and paresthesia common in the legs. Bowel and bladder dysfunction also can occur. Diagnosis is spinal MRI is diagnostic. Treatment is corticosteroid and supportive therapy. Disorder of neuromuscular junction. This is an 11 years old girl, presents with 5 weeks history of double vision, droopy eyelids. She feels tired and weak, especially at the end of the day. Her symptom always worse in the evening. Neurological examination is normal. What is the most likely cause of her symptoms? This is a classic presentation of myasthenia gravis. Myasthenia gravis can be neonatal or congenital. Neonatal is maternal anti-acetylcholine receptor antibodies transferred transplacentally from the mother to the baby. The newborn may present with ptosis, feeble cry or weak cry, poor suck during the first few days, usually resolve within 3 to 5 weeks. Congenital is familial, not transferred via the mother, no antibodies, and it is multiple subtypes. Juvenile myasthenia gravis is more common in female than males. The onset is more than 10 years of age. Clinical symptoms: generalized weakness, fatigability of the muscle, especially at the end of the day, ptosis, and ophthalmoplegia. Diagnosis of myasthenia gravis: anti-acetylcholine receptor antibodies is the study of choice, not hydrophonium anymore. This test is not used anymore. Ice pack test by applying the ice pack above the eyelid, and this can improve the ptosis and diplopia, and this test is popular between ophthalmologists and suggested because of improvement of transmission through the neuromuscular junction. EMG: decremental response after repetitive stimulation. Treatment is prednisone or steroid, anti-acetylcholine esterase drugs, thymectomy in severe cases, IVIG, immunosuppression. Botulism is toxins from the Clostridium botulinum, which is anaerobe. The two most common sources of ingestion spores are the honey and soil, especially in infants less than 12 months. So it is contraindicated to give any infant less than 12 months regular honey because of the spores and risk of botulism. Clinical presentation: gradual onset of hypotonia. The child will become weak. Constipation could be the initial symptoms. So weakness and constipation or poor feeding is a red flag for botulism. Poor suck or poor feeding, poor swallow, feeble cry or weak cry, and sluggish pupil. Diagnosis of botulism is isolation of toxin from the stool. This is important and high yield in the board. The isolation of toxins from the stool in cases of botulism. EMG will show fibrillation potentials and decremental response on repetitive nerve stimulation. Treatment is botulism immunoglobulin. Supportive care: many patients they go for respiratory failure and they require intubation. Primary muscle diseases. Duchenne muscular dystrophy: the genetics of this disease is X-linked recessive disorder, only affects males, so incompatible with girls, so is only affecting males and boys. Absence of dystrophin: this is the key for, or this is the pathology, is absence of dystrophin gene. 30% of the cases are spontaneous mutations. The physical examination or symptoms: normal newborn, so these children are born normal with no symptoms. Then as they grow they start to show symptoms of weakness, waddling gait, and poor head control. Also, they may have difficulty standing or climbing, which is well known as Gower's sign. Hypertrophy of the calf, pseudo-hypertrophy, generally unable to walk after 12 years of age. They die in most of the cases by age of 20. And one of the complications they will have is dilated cardiomyopathy. Diagnosis of Duchenne muscular dystrophy is elevation of the CPK. CPK is elevation is suggestive, but the elevation here is not just to 100 above the normal or 200. Usually they will be in thousands. 12,000, 20,000 is just a very high level. Muscle biopsy is diagnostic. Genetic testing for dystrophin gene. EMG will show characteristic myopathic features of the muscle. Echo, EKG, chest X-ray, very important for cardiac function. The treatment is supportive. There is no cure, and physical therapy. Corticosteroids are sometimes recommended to delay wheelchair use. Becker's muscular dystrophy, the defect is the same as Duchenne muscular dystrophy. The symptoms and the examination, the symptom onset later than Duchenne patients. Patients ambulatory until late adolescence and early adulthood, so they survive more than Duchenne. Becker's patient can also present with cardiomyopathy. Diagnosis of Becker's muscular dystrophy: creatine phosphokinase elevated or elevation of CPK. Muscle biopsy is diagnostic. Genetic testing for dystrophin gene. Echo, EKG, chest X-ray to evaluate for cardiac function. Similar to Duchenne, supportive care and physical therapy. Congenital myotonic dystrophy: the genetics of this disease is autosomal dominant. CTG, trinucleotide repeat expansion of chromosome 19. The inheritance is generally from the mother, and the symptoms become more severe with each successive generation. This is well known as genetic anticipation. Clinical presentation of congenital myotonic dystrophy: hypotonia in the newborn. One of the differential diagnoses of hypotonia: hollowing of the temporal bones, feeding issues or poor feeding, respiratory distress due to intercostal and diaphragmatic weakness, arthrogryposis. Some patients may have cataracts. Diagnosis is DNA testing for CTG repeats, and CPK in this case is not useful, so is usually normal. Treatment is supportive care and physical therapy. We'll start a new section, neuropathies. Acute inflammatory demyelinating polyneuropathy, Guillain-Barré syndrome. This disease is post-infectious polyneuropathy after infection. It results in paresthesia or abnormal sensation and ascending symmetrical peripheral neuropathy. So ascending weakness or ascending muscle weakness is a key word for Guillain-Barré syndrome. This disease occurs in healthy individuals days to weeks after previous infection or antecedent illness. Miller-Fisher variants, when the disease goes to the central part or the cranial nerves, they may present with facial weakness, ophthalmoplegia, ataxia, and reflexia, and this is well known as Miller-Fisher variant. Causes: Campylobacter jejuni is common, Mycoplasma pneumoniae, autoimmune conditions, surgery, and vaccination, for example, after influenza vaccine. Clinical presentation of Guillain-Barré syndrome is weakness. This is the most important symptom of Guillain-Barré syndrome is weakness, and the weakness start distally and start to ascend. So the ascending weakness is a key word for Guillain-Barré syndrome. Diminished or absent reflexes, so associated with diminished or absent reflexes. Absent reflexes is another key word. Paresthesia or pain, especially in the lower leg, is common. Autonomic instability can occur in severe cases like arrhythmia, orthostatic hypotension, hypertension, bladder dysfunction. Know that acute illness of Guillain-Barré syndrome peak in severity in 2 weeks, and the recovery takes a long time, weeks to months to recover. Know that facial nerve weakness, especially bilateral facial nerve weakness, is a common association with Guillain-Barré syndrome. So the most common cranial nerve affected with Guillain-Barré syndrome is facial nerve, and usually bilateral. Diagnosis of Guillain-Barré syndrome is primarily clinical. Preceded infection followed by weakness and absent reflexes, or ascending weakness and absent reflexes. This is the key word for the diagnosis of Guillain-Barré syndrome. CSF is very helpful if it shows the elevated protein without elevated cell count. Is well known as albuminocytologic dissociation. This is also another key word, albuminocytologic dissociation, which is elevated protein with no elevated cells. EMG, it takes weeks to show the positive finding, and the first abnormality is F wave. Nerve conduction studies are slow with evidence of conduction block. Management of Guillain-Barré syndrome is immediate hospitalization, immediate IVIG and plasmapheresis, supportive care, and hospitalization until the patient is stabilized. PQ in cases of bulbar palsy, for example facial palsy, vital capacity is compromised, autonomic instability. Course and prognosis. Prognosis in childhood is excellent, for recovery within 6 to 12 months, with majority of those who do not recover fully having only mild disabilities. Charcot-Marie-Tooth disease, the characteristics is the most common inherited peripheral neuropathy. Defective peripheral nerve myelination, deep tendon reflexes are markedly diminished or absent. Vibration sense and proprioception are significantly decreased. Pain and temperature sense are intact. Diagnosis: genetic testing, electromyography, nerve conduction studies. Charcot-Marie-Tooth type 1, autosomal dominant, demyelinating condition, asymptomatic until late childhood or adolescence. Physical exam will be significant for palpable enlargement of the nerves. Charcot-Marie-Tooth type 2 is autosomal dominant or recessive, axonal condition, and onset in childhood and associated with severe wasting of calf muscles, with piscavus and wasting of the dorsal interossei of the hands, associated with foot drop. Ankle foot orthosis is necessary to help with foot drop. Spinal muscular atrophy or SMA is autosomal recessive, affects the anterior horn cells, so is lower motor neuron. Characterized by 3 different types, range in severity, type 1, type 2, and type 3. The common type 1, well known as Werning-Hoffmann, and this usually appears in the first 6 months of life with severe hypotonia. So any newborn presents with severe hypotonia, one of your differential is spinal muscular atrophy, and also they will have in the presentation frog leg position, difficulty feeding. Very important finding and key word for SMA is tongue fasciculations or twitching. atrophy or muscle atrophy. So the muscle wasting is unique about the lower motor neuron lesion, and this disease affects the anterior horn cells. No sphincter loss, no sensory loss, the cognition is okay. So these functions are normal, the sphincter and the sensation and cognition. Diagnosis is genetic mutation screening. Management is supportive, respiratory, nutritional, and orthopedic support. Familial dysautonomia. Definition is inherited neuropathy affecting sensory and autonomic nerves. So the clinical presentation is insensitivity to pain, temperature dysregulation, difficulty feeding, blood pressure instability, vomiting, and sweating spills. Let's take a break with this case. This is a case of Bell's palsy. Which patient is requiring imaging study, A or B? Which one is upper motor neuron? Which one is lower motor neuron? Which side is affected? This patient, just to give you more information, the eye exam is normal. So this adolescent presents with unequal smile and numbness on the right side. His eye exam was normal, and the weakness here is significant on the right side. The left side is healthy. So we did MRI, and it showed multiple sclerosis focus or lesion on the left side. This case is a case of peripheral nerve facial nerve palsy or Bell's palsy. This child, while crying, he's not able to close the left side or the left eye, and also the cry here is unequal. He's pulling more on the right side, so the right side is healthy. And the left side is the side affected here. So this is a peripheral nerve facial palsy, or what is well known as Bell's palsy. The treatment here is supportive. No imaging study is necessary. Movement disorders. Acute cerebellar ataxia is relatively common in children, often in the second decade of life, most commonly associated with viral infection or cerebellitis. Common association is varicella. Causes infectious or post-infectious can be associated with posterior fossa tumors, neuroblastoma, trauma, acute hemorrhage, toxic, for example, alcohol or benzodiazepine. Clinical presentation of acute cerebellar ataxia. Rapid onset of ataxia over hours to days, typically manifest as gait disturbance. Also, the child can have a problem with reaching objects or speech. In the study of the CSF, you will see pleocytosis. MRI will show enhancement. Prognosis usually self-limited. It may take several weeks or months to complete resolution of symptoms. This 7-year-old girl, she's having Ataxia-telangiectasia. This is a classic presentation of Ataxia-telangiectasia. Ataxia-telangiectasia is autosomal recessive. The causative gene is Ataxia-telangiectasia mutated gene located in chromosome 11. Clinical presentation, the onset by 2 to 3 years of age, so appears in younger age or in younger children. Impairment in coordinated muscle movement involving the gait, trunk, and limbs. Progressive symptom lead to the loss of ambulation in childhood. Movement disorders precedes the oculocutaneous telangiectasias. Jerking movement of the eye and oculomotor apraxia or inability to look in the way or the area where the child wants to look. Immunologic deficiencies increase in the pulmonary infections like recurrent sinus and lung infection, like in the case we had in the previous slides. Cerebellar degeneration, increased sensitivity to radiation. So please do not order X-ray or CT scan for these kids with Ataxia-telangiectasia. They are super sensitive to the radiation and can cause tumors or leukemias. So you can use alternatively ultrasound or MRI or other modality of imaging, but not X-ray or CT scan as much as possible. Increased risk of lymphoreticular neoplasm, leukemia, and lymphoma. Diagnosis of Ataxia-telangiectasia from the classic clinical presentation. Unique laboratory finding in cases of Ataxia-telangiectasia is elevated alpha-fetoprotein. So remember this association, elevated alpha-fetoprotein with cases of Ataxia-telangiectasia. Decreased serum immunoglobulin, IgA deficiency, IgG, and IgE deficiency. That's why these patients, they have recurrent sinusitis and lung infection. Prognosis often wheelchair bound by 10 years of age, and the median survival is about 25 years. Friedreich ataxia is autosomal recessive disease. This disease appears commonly during adolescence. Remember, Ataxia-telangiectasia appears during childhood. Friedreich ataxia appears during adolescence. Progressive trunk and limb ataxia, muscle weakness, high arched feet, dysarthria or problem with speech, loss of deep tendon reflexes. Also, they will have upgoing plantar response, sensory neuropathy, loss of vibration sense and proprioception. Scoliosis is common, cardiomyopathy is common, diabetes mellitus is seen in up to 30% of the patients. Diagnosis and management of Friedreich ataxia, specific genetic testing typically will occur within 10 years after the onset of the symptom. The management is symptomatic and supportive. It's important to be familiar with tics because it's common in pediatrics. It is intermittent, sudden, discrete, repetitive, non-rhythmic movements or vocalization or both. Tics typically occurs multiple times per day. Types: motor and vocal. Motor involve the skeletal muscle, can be simple movement or complex movement. Vocal can involve the diaphragm, laryngeal or pharyngeal muscles and can be also simple or complex sound. Simple motor tics is the most simple, most common. This involves a single muscle or localized group. For example, repetitive eye blinks, facial grimacing. Simple vocal tics, for example, throat clearing, sniffing, coughing, or grunting. Complex motor tics is more complex movement. For example, head shaking, trunk flexion, finger tapping, or jumping. Complex vocal words, for example, corpolalia, like uttering swear words, for example, cursing or saying bad words. Echolalia, repeating the words or phrases of others. Epidemiology of tics: approximately 20% prevalence is common, more in boys than girls, typically appears in the first decade of life with a median age 6 years of age. Most of the kids, they improve with no interference by late teens or early adulthood. Most common presenting is a tic eye blinking. This is very common in pediatrics. Tics are often preceded by urge or sensation, sometimes manifestation as non-specific anxiety. Performing tics relieve the urge or this anxiety. Tics are often be suppressed for a short period of time, can be exacerbated by environmental stimuli, stress, or poor sleep. Tics typically do not occur during sleep. This is important. Commonly associated with ADHD and obsessive compulsive disorders. Management of tics requires only reassurance, anticipatory guidance, and education. Educate the parents that this is self-limited and there is no associated significant problem with simple tics. Often no medication is required. If sufficient morbidities affecting the child, for example school or education, clonidine or guanfacine is the first line of treatment. Behavioral therapy, positive reinforcement. Treatment of comorbidities like management of ADHD, obsessive compulsive disorder, and anxiety. So reassuring the parents is important. For example, if the child is presenting with eye blink, ignore the behavior. Positive reinforcement, reassure the parent that this behavior will disappear with time. When motor and vocal tics persist for a long time, the name will change to Tourette syndrome. The Tourette syndrome is more common in boys than girls, associated usually with behavioral problems, for example, ADHD, OCD, anxiety, and depression. Diagnostic criteria: to meet the criteria for the diagnosis of Tourette syndrome, presence of both motor and vocal tics together. So it has to be both. Duration of tics more than 12 months, no tic-free interval more than 3 months duration, age of onset less than 21 years of age. Management of Tourette syndrome: non-pharmacologic, which is behavioral treatment. Pharmacologic: for mild cases, alpha adrenergics, clonidine or guanfacine. For more severe cases of tics, typical and atypical neuroleptics. Surgical treatment also another option. In severe cases, deep brain stimulation. Sydenham chorea is a frequent, brief, purposeless movement that flow from one body part to another that are chaotic and unpredictable. Sydenham chorea is one of the major criteria of acute rheumatic fever. The most common age is between 5 to 15 years of age. Sydenham chorea will be discussed in details in the infectious disease chapter. Cerebral palsy is very important. Know that most common cause of cerebral palsy is prematurity and low birth weight, not hypoxia. Not hypoxia. The most common cause of cerebral palsy is prematurity and low birth weight, not hypoxia. Definition of cerebral palsy, it is non-progressive. This is very important word to keep in mind. It is non-progressive disturbance that occurred in the developing fetus or infant's brain. The incidence of cerebral palsy, it is common, 2.5 per 1,000 births. The key aspect of cerebral palsy is a disorder of motor function, not sensory. It is just motor function, not sensory. The clinical manifestation of the disorder may change over time. For example, atrophy of the muscle, more spasticity of the muscles, but the causative lesion is static, which is the brain lesion is static, doesn't progress. Red flags and the early detection of cerebral palsy. This is really essential, especially in mild cases of cerebral palsy, to keep paying attention to these red flags. Severe cases of cerebral palsy will be apparent from the beginning, even to the parents. Red flags, so the clinician should pay attention to these signs, and it may help you to identify this disease early. If the infant starts to roll at a younger age than 3 months, this is a red flag because of possibility of hypertonia. Normally infants, they roll at 4 to 6 months, not before 3 months of age. Lack of head control in a child also demonstrating scissoring, which is indicating hypertonia of the legs. Persistent to primitive reflexes, for example, motor reflex beyond 6 months of age, or grasp reflex beyond 4 to 6 months of age, is a red flag. Not sitting well at 9 months, not pulling to stand by 12 months. Persistence of TB2 walking. TB2 walking is a red flag for cerebral palsy and may be the only symptom in mild cases of cerebral palsy. TB2 also can be a significance for Duchenne muscular dystrophy. Know that if no motor delay is not a cerebral palsy. If there is no motor delay, there is no motor problem, is not a cerebral palsy. Cerebral palsy is a motor disease, not sensory. General manifestation of cerebral palsy: delayed motor milestone, abnormal muscle tone, hyperreflexia, hand preference before age of 1 is a red flag for possible hemiplegia or hemiplegic cerebral palsy, growth disturbance or failure to thrive, constipation, seizures, intellectual disability between 25 to 75%. So you will have some types of cerebral palsy where the child is intelligent and is able even to go to the college. We'll continue with the manifestation of cerebral palsy: persistence of developmental reflexes, as we mentioned before, presence of pathologic reflexes, failure to develop maturational reflexes such as parachute response at 6 months. Clinical manifestation may change with maturation. No evidence of disease progression or developmental regression. Diagnosis of cerebral palsy from the history and physical exam. It's a clinical diagnosis including thorough neurological examination, review of pregnancy and delivery record, especially prematurity, neuroimaging, preferably MRI. Ophthalmologic and auditory evaluation is essential. Speech and language evaluation. Metabolic and genetic testing should not be done routinely unless there is atypical clinical presentation and non-specific neuroimaging study. Electroencephalogram or EEG if concern for seizure, but generally is not indicated. Management and complications of cerebral palsy. It is family-centered care. Is not just one person. It is a multidisciplinary approach. Symptomatic treatment of seizures, symptomatic treatment of spasticity. Be familiar with medicine for spasticity. Cerebral palsy patients, they are using oral baclofen or baclofen pump, botulinum toxins and diazepam. Orthopedic management of contractures and scoliosis. Use of orthotics, very important. Also, physical and occupational therapy is essential. Learning and cognitive evaluation. Management of constipation, which is one of the most common complications with cerebral palsy. Monitoring of swallowing and gastrointestinal reflux. Reflux also is common. Obstructive sleep apnea and the risk of aspiration and aspiration pneumonia. Development of restrictive lung disease secondary to scoliosis should be addressed. Management of sleep problems, dental care, increased risk of malocclusion, dental caries and gingivitis, so dental referral is important. Types of cerebral palsy. Spastic is the most common, 70%, and spastic 3 types: hemiplegia or hemiplegic type, diplegic type, and quadriplegic type. Dyskinetic, chorioathetoid, and dystonic, and hypotonic type, and mixed. This table is to summarize important types of cerebral palsy. The first one is spastic hemiplegic cerebral palsy. The most common cause is intrauterine stroke and maternal cocaine abuse. The red flag is early hand preference. You will see the infants preferring to use the right or left hand before 1 year of age. This is red flag. Circumductive gait with toe walking. Growth arrest of the abnormal side and will be more prominent in the distal part of the arm and the leg. These children with hemiplegic cerebral palsy, they have high function intelligence, so they can go to the college and they function like other normal children. Spastic diplegic cerebral palsy affect the lower limb. The most common cause is prematurity. Toe walking is a red flag in older children. Scissoring of the legs when held in vertical position is classic in the physical exam. Growth arrest of the lower limb. Intellectual disability can be present. Spastic quadriplegic, which is affecting all the limbs, upper and lower. The most common cause placental abruption like trauma during pregnancy, hypoxic events like hypoxic ischemic encephalopathy, early presentation feeding difficulties, decreased limb movement, flexion contractures of the elbow and wrists, spasticity of the hip muscles may lead to subluxation. Learning and intellectual disability is common with quadriplegic cerebral palsy. Dyskinetic cerebral palsy, the common causes hypoxic ischemic encephalopathy, kernicterus, which is ataxic or high level of bilirubin crossed the blood-brain barrier. Large amplitude involuntary movements, athetosis or writhing movement or chorea. Seizure and intellectual disability can be also present with dyskinetic cerebral palsy. This is the last case of my presentation. This is a 3 years old girl with developmental delay, recurrent seizures, not able to stand anymore, no eye contact, not speaking anymore. Physical examination, she is underweight, continuously moving her hands in a hand washing movement. Occasionally she holds her breath and sometimes hyperventilate and has scoliosis. What is the most likely cause of her symptoms? Important information in this case is a girl with developmental delay, recurrent seizures. There is also developmental regression. She's not able to stand anymore, no eye contact, not speaking anymore, so there is a developmental regression and autistic manifestations. Also, she has abnormal movement with her hand washing movement. She holds her breath. Also, she has scoliosis. This is a classic presentation of Rett syndrome. Rett syndrome is X-linked, the mutation in MECP2 gene. You need to memorize this gene because it comes in the board all the time. Males with mutation in this gene, typically they will die before or soon after birth. So this syndrome is with girls, not boys. So in the exam also or clinically, the presentation will be with girls, not boys. Clinical features, the neurological regression, as we mentioned in the case, starting between 1.5 to 3 years of age, with loss of acquired hand skills and spoken language. So the child was speaking, then start to lose these skills and not to speak anymore, or not to be able to use the hand skills anymore like before. Autistic features with social withdrawal, like in this case she was not having eye contact. Extreme irritability and anxiety. After regression there is a stabilization of skills afterward. Also, girls with Rett syndrome, they present with severe intellectual disability, motor abnormalities like ataxia, apraxia, dystonia. Seizures are common, acquired microcephaly, so measuring the head circumference is important when suspecting Rett syndrome. GI abnormalities like GERD, constipation, scoliosis, sleep disorders, bruxism. Bruxism is habitual teeth grinding. Diagnosis of Rett syndrome is clinically from the specific clinical features we discussed before to be present in a girl, specific genetic testing mutation in MECP2 gene, abnormal EEG, MRI initially normal, then later on will show generalized atrophy of cerebral hemisphere. Treatment: there is no cure for Rett syndrome. Only symptomatic treatment can be offered, like for example anti-seizure medication for seizure and anti-reflux medication for GERD. This is the end of this presentation. Thank you.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you. Presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams, crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lectures' PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This lecture is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.